Yeah, the author is the presenter. The title is the COVID-19 status at Thika level 5, and more so the emphasis on the role of the nurse and the midwife in the COVID-19 management. And my institution is Thika level 5 in Kiambu County. Background: the coronavirus COVID-19 is caused by severe acute respiratory, which is coronavirus SARS-CoV-2, which was first detected in December 2019 at the wet market in Wuhan, China. Early 2020, the WHO declared the COVID-19 as a global pandemic as it spreads across several continents, causing a high mortality rate in most countries were affected. Africa confirmed its first case in February 2020 in Egypt, and as by June 2021, 47 African countries were affected, with an estimation of over 3 million confirmed cases and over 94,644 deaths. In other phrase, Africa seems to be the least hit continent on a comparative note. The clinical spectrum of the disease is quite variable, ranging from undiagnosed asymptomatic infections through mild upper respiratory infection to severe viral pneumonia leading to respiratory failure and death. The incidence of respiratory failure in Wuhan was at 54 overall, with 90% getting to respiratory failure and a rate of 36% that survives. The pandemic has not yet led to increased mortality, but has also resulted in the widespread socio-economic disruption and severity in the affected countries. The effect may be observed in countries with relatively low-resourced system in terms of the healthcare. The healthcare workers are usually the first point of contact during an epidemic and are susceptible to infections, diseases during the outbreak. The healthy impact of the COVID may differ in African settings compared to Europe and China due to the demographic and epidemiological and environmental and social factors. Our objective was to establish the status and the role of the nurse and the midwife, a retrospective review of the data with a sample of 126. On a demographic note, you realize that the number of patients that were seen between 35 and 50 years were at 16%, 51 to 70 years at 49%, and 71 to 90 years 35%. We had more male who were admitted with the same at 54 against 46 in female. Comorbidities, we looked at patients who had a comorbid of hypertension, diabetes, and COVID as well at 31.8, hypertension at 33.3, and those who had only COVID at 34.9%. Immunization status, a number of people that were immunized fully were at 17.5 against 82 who had a partial or no immunization was done by then. Recommendations and conclusions is that the nurses, being the main immunizer, should work hard to ensure community uptake improves in terms of immunization. Nurses should improve health education and means to adherence on the protocols and personal initiative towards immunization. More male patients were infected with COVID-19 on a comparative note. Individuals with comorbid were more prone to infection with COVID-19 compared to others. There was low uptake of immunization among the male as compared to the female. There is need for nurses and midwives to intensify health education to the community on adherence matters and follow up on the outpatient clinics. Sensitization among the community on immunization is still important. I would wish to acknowledge the following people: our county government, the management of the hospital, and the ethical committee for the ECSACON. Thank you, colleagues.